And our next speaker, Dr. Othman AlHarbi, consultant gastroenterologist, IBD specialist in King Abdulaziz King Saud University Hospital in Riyadh. And he's one of the most active IBD consultant at the level of the kingdom. He added a lot to the local understanding of the disease. And today he's talking to us about the therapeutic drug monitoring in IBD.
Thank you for this nice introduction, and thanks for the organizing scientific committee for giving me a chance to present today. So what we'll talk today about the therapeutic drug monitoring is inflammatory bowel disease in general, and the two lectures before me actually, they paved the road for my lectures. So if we look at the approved biological therapy by FDA in inflammatory bowel disease in general, we already been using anti-TNF for a few years now, and be more comfortable using them. There's a new kids in the blocks as been described in the two first lectures. But as Professor Colombil mentioned in his slide, if you look at the actual number of patients who maintain remission and at 1 year, it will be around 25 to 26% of the patients, and there is around 50% of them they will have a response in the first with the induction, the first 14 weeks, and at the end of the year, 50% of the people who responded in the first 14 weeks will lose response. Will end at the end of the first year, will have 26% of the response, and this is mainly happening because of a different mechanism. And one of the main things is the emergency and the anti-drugs antibodies that develop in these patients. The other things that patients lose response to the anti-TNF therapy in general, and biological in general, and the anti-TNF specifically, is the enhanced drug clearance, the alternative inflammatory pathways. Sometimes we deal with non-inflammatory complications like strictures or abscess formations or IBS. IBS or concurrent infection as a side effect of the immunomodulators or the anti-TNF therapy as C. diffs or CMV viruses. So I will start with one of my patients who's a Haifa. She's 16 years old, and majority of you, I'm sure, dealing with a pediatric patient as in my practice. She's 16 years old. She presents with abdominal pain, diarrhea, and weight loss. She was having these symptoms for around 1 year before coming to me. She only came to me, been referred to me after she developed perianal fistula. We diagnosed her with the Crohn's disease. Her disease was mainly colonic and TI. In endoscopy, when we did for her an MRI angiography, there was extensive colonic inflammation and also TI inflammation. And we started her immediately with anti-TNF therapy in form of infliximab combined with the azathioprine. She's been followed in our clinic, usually which is every 3 months in our clinic, and she's receiving her infliximab every 8 weeks in the infusion centers. After 8 months, she was still doing well clinically, and we normalized all her inflammatory markers, mainly CRP, and there was a closure of her perianal fistula. I usually do the infliximab level and the HACA antibodies for our patients. I usually do them week 14 with the 4th dose, and after that I do them every 3 infusion, especially in my private clinics. And this is just to monitor and try to improve the outcomes for our patients. So for the therapeutic drug monitorings, if you look at how we can use the drug level and how we can use the antibodies in optimizing the response to the anti-TNF therapy mainly, and also for biologics in the futures. The first things, we look at this data, which is a sub-analysis or an analysis for patients with accident trials, where they look at what are the markers that they could predict in week 14 that could predict the response at the end of the 1 year. And what they found in this study, that the 2 markers, when they use infliximab 5 milligram per kg, that could predict response at the 1 year. This is what we talk about, the 25% who respond at the end of the 1 year, when they found that the drug level was more than 3.5. This is one of the predictor markers. And the other predictor marker they found in this study was a decrease in the CRP by more than 60%. So doing the drug level at week 14 could predict the response of our patients in 1 year with Crohn's disease. When you look at ulcerative colitis, again, same study trying to look for, it's a different study actually, but they're trying to look for the predictors of response at week 14, a long-term response on ulcerative colitis patient, and what they found, again, a trough level more than 2.5 in week 14 could predict the response at the end of 1 year. This was true not only for infliximab, but also for glumamab. When we look at the sub-analysis for Pursuit study, that drug level more than 1.4 was associated with clinical response throughout week 54, and also mucosal healing week 30 and 54, and clinical remission. Again, with the ustekinumab, this study was done from McGill University, from Montreal group, when they look at 1 year response to the ustekinumab in their patient, and they measure the drug level at week 26, what they found that drug level more than 4.5 at week 26 was associated with a mucosal healing at the end of the 1 year, 76 to 41% for the endoscopic remission, and for the endoscopic response, and for the endoscopic remission was 28 to 11%. So what the question is, we ask ourselves why the drug level is different from one patient to another. Even that majority of the medication we are using is a weight base, as in infliximab, and also in ustekinumab. The drug level different between patients because, of course, the anti-drug antibodies increase the clearance. The use of immunosuppressive medication can decrease the clearance. And some patients with high inflammatory burden, especially with acute fulminant ulcerative colitis, where the TNF level is very high and we require more medication than usual. The other factors was also found to the male genders, where there is increased clearance and the body mass index. And we know that with the biological treatment and the anti-drug levels, when we look at the trough level for the anti-TNF, it's usually significantly lower in patients losing response to the medication. It's lower in patients without a mucosal healing. And when we look at the HACA antibodies, it's usually associated with lower trough level, also associated with losing response to the anti-TNF and infusion reaction. But we have to keep in mind the anti-drug antibodies, they usually fluctuate over time, and sometimes even that it's positive at the beginning, they may clear with time. And how we can customize our treatment depending on the drug level and the HACA antibodies. This study was done by Waqas Afifi from Montreal when he was doing, I think, his fellowships in Leuven. They found that when they retrospective look at their cohort of patients, when there is detectable HACA antibodies, the best way of managing these patients is actually to change the anti-TNF therapy with a p-value, significant p-value, compared to the patient with subtherapeutic drug level with negative HACA antibodies. In these patients, they could either decrease the interval of giving anti-TNF therapy or increasing the dose, and also was a significant p-value. So when we have symptoms suggestive of a loss of response to our patients, we should measure the antibodies. With the trough level being detectable, we should look if there is any sign of intestinal inflammation, doing either by non-invasive marker through the calprotectin or through the endoscopy. When there is active inflammation, in this patient, most likely the anti-TNF is not the best medication for this patient, and we should change a class for these patients. For patients with detectable antibodies and there is no sign of endoscopic inflammation or mucosal inflammation, these patients we should look for secondary causes like irritable bowel syndromes or or complication of IBD like strictures. For trough levels is antidetectables. We depend on what's the level of the antibodies. If the level of the antibodies is high, more than 8, this patients will benefit with it changing to another class of anti-TNF. If the level is low, some of these patients will respond well when we increase the dose of the anti-TNF or decrease the interval. This is talking about the same things. Just the first things we have to confirm the IBD-related inflammation. If there is adequate drug levels, we measure the antibodies. Either we intensify the dose or switch to the other anti-TNF therapy. If there is no IBD-related inflammation, we should look for complication like fibrosis or IBS for our patients. This is the TAXIT algorithm that Professor Colombil mentioned about in his study, where they look at the patients and they randomize the patient depending at the drug level. If there was undetectable drug levels, they measure the antibodies. If the antibodies is high, they stop the medication. If the antibodies is low, either they increase the dose by 5 milligram to maximum 10 milligram per kg. If the level is detectable but is still lower than 3, they either decrease the interval between the anti-TNF or they increase the dose. If the dose of the drug level is more than 7 microgram per ml, they actually increase the intervals. And they try to keep the patient all the time between 3 to 7 microgram per ml, and there was no dose adaptation in these patients. So this is actually an important slide, because when they look at their patients who are in the clinical response, so all these patients what you see in this figure are in clinical response. Only 44% they have actually desirable drug level. Around 30% of them, they have actually either no drug level or it was low. And when we look in our data in our hospitals, almost the same things. Around 30% of our patients, they have low or undetectable drug level. And 26% of them, they have high drug level. This is also important because it actually could save some of the cost of the anti-TNF medication in these patients, either by increasing the intervals or by stopping the medication for these patients, as there is no benefit for some of these people. So when they look at the optimization phase and the de-escalation for the de-escalation phase, what they found that that's patient with subtherapeutic level in Crohn's disease, there was a significant improvement in Harvey-Bradshaw index from 64 to 88%, and also a significant decrease in the CRP in patients with the Crohn's disease. And for patients with ulcerative colitis, there was a trend toward improvement in the Mayo score and a decrease in the CRP, but what was not statistically significant in these patients. What about the de-escalation? They managed to de-escalate in patients with high trough level, and what they found there, even that there was some decrease in the Harvey-Bradshaw index and the Mayo score that was not clinically significant. Also, there was no significant difference in the CRP after they decreased the dose or the increased interval with IBD patients. So we'll go back to Haifa. So I saw her at that time. She was still clinically doing well. There was no symptoms. Her caloprotection was continued to be within normal. So what I did for her is change the interval to every 6 weeks, and she was doing well till 6 months and present again with abdominal pain and diarrhea. And every time we see our patients with loss of response, what we ask ourselves, are we dealing with an infection? Are we dealing with an activity for the Crohn's disease? Her stool culture, the C. diff was completely within normal. We look at the disease activity. There was a return of the inflammation. We did for her colonoscopy, and we take biopsy to rule out CMV. And We repeat for her the MRI, there was no strictures, no abscess, and of course we know that she is adherent to the medication because she's taking it in our infusion centers. The infliximab level at that time was undetectable and the HACA antibodies were high. And I switched her to adalimumab. I saw her 2 months after that, 2 weeks ago, and she was still continuing to do well. So what I think the drug level should be measured in the antibodies, the main things, as I mentioned in my presentation here, is shortly after the induction, especially at week 14, could predict who are the patients who will respond at the end of the 1 year, and also in patients who continue to be in remission. And this will help me either intensify the anti-TNF therapy or decrease the dose. Of course, if there is a disease flare, and this is distinguished between the pharmacokinetic and the pharmacodynamic issue. Also, the other things, even that there is no strong evidence for it, where I use it when the patient won't de-escalate from combo to monotherapy infliximab, I try to look for the antibodies for these patients. Could help me regarding to try to predict the inflammation after de-escalations, and of course after stopping the anti-TNF therapy. The other way of doing it is looking for to monitor the adherence, especially in sub-Q agents, mainly the adalimumab. And what usually we measure the drug level is 24 hours before the IV infusions, and for the medication that's been taken as subcutaneous, especially the adalimumab, there was no difference in the timing of taking the trough levels. Could be taking usually at any time. There is no big variation in the drug level in the blood. The other way I think the drug level should be measured is when there is a severe flare, especially with acute fulminant ulcerative colitis, and this is to guide you what will be the usual required dose to manage these patients, especially when we know from clinical practice that 5 milligram or 10 milligram per kg maybe is not enough for them because of the high inflammatory burden for these patients. So in conclusion, therapeutic drug level and anti-drugs antibodies show promise as a therapeutic guide for the patient, and I'm sure it will be more and more in the futures as we have more study to define the therapeutic range and how we could use it effectively to optimize the response to anti-TNF therapy, and especially it's useful in patients with the loss of response to anti-TNF therapy. Thank you.
Thank you so much, Dr. AlHarbi, for this outstanding presentation. Our next presentation will be a prevention of post-operative recurrence in patients with Crohn's disease. Speaker is Dr. Talal Al-Tawil, consultant gastroenterologist in Mubarak Al-Kabir Hospital, Hayy Al-Habib Center in Kuwait. Dr. Al-Tawil completed his medical school in the Republic of Ireland. After finishing internal medicine training, he went to McGill University, where he completed gastroenterology and IBD fellowship. He published multiple papers, including being an author and co-author in meta-analysis from the Cochrane Group in Canada. Dr. Al-Tawil.
Bismillah wa salatu salam ala rasulillah wa ala alihi wa sahbihi wa man wala. Assalamu alaikum. Good morning, everyone. And thank you, Mr. Chairman, for the kind introduction. It's always a pleasure, really, to come back to Riyadh, and a big thanks to SJ for inviting me. It's a real pleasure to participate in your AGM, and real honor. These are my disclosures. So the topic I've been assigned is, today we've gone through a trip in IBD where we started with some treatment strategies. We talked about when can we use biologics, and maybe the timing for using biologics. And then Dr. Uthman talked to us about how we can optimize our drugs. And now we come to the stage where we've actually failed. So this is a group of patients where now we can consider that we've failed them from a medical perspective. They've gone under the surgeon's knife, and now they come to you in the clinic. And you don't want them to go to the OT again. So what I'm going to go through in this 15 or so minutes is really to see if we have any tools available to us that can maybe reduce or prevent post-operative recurrence in Crohn's. I'm going to give you a brief introduction. These are my objectives. Talk about the risk factors that we have for postoperative recurrence, and the tools that we have available at our disposal. And then I'll talk about some of the medical prophylactic therapy that we have, and then hopefully you can leave here with some practical take-home messages that you can use in your everyday practice. So despite our very impressive armamentarium that we have now in 2018, unfortunately, approximately 50% of our patients do require a bowel resection within their first 10 years of their disease. Now, as we know, unlike ulcerative colitis, surgery in Crohn's disease is not curative. So, and out of these patients that do undergo a resection, 25% will require at least another resection within 5 years of their index surgery. And we have to be really clear with our patients that postoperative recurrence is inevitable. So it's really just a question of when it's going to happen. And that rate really varies upon which criterion is used. So if you use an endoscopic one, it's higher, it's around 30 to 90%. That's more of at 1 year. That's an objective one. But if you use the clinical ones, it's slightly lower. And if you look at, for example, the surgical recurrence, that's a bit lower. So it just depends on what criterion is used. And these criteria have evolved in clinical trials for prevention, as we can see, where we've moved from more subjective clinical criteria to more objective criteria such as endoscopic recurrence. So a lot of risk factors have been studied in the literature. I'm going to go through the ones really with the stronger evidence base, so which are really, number one is active smoking, having a penetrating or perforating phenotype, having a previous intestinal surgery, and then I'm going to tell you about a few interesting histological ones, which I don't routinely use, but they're quite interesting. They do have an evidence base behind them, like granulomas and myenteric plexitis. Now, I'm not going to go through the evidence base on the right, but there's basically age, gender, disease duration, resection margins, type of surgery. There's either conflicting data or the evidence is from uncontrolled trials. So start with smoking, which is really the strongest risk factor that we have for postoperative recurrence. So this was a large meta-analysis published in 2008 of around 3,000 patients looking at 16 observational studies, which showed that the odds ratio was around, smokers had almost twice the risk of recurrence as non-smokers. However, what was actually good about this, though, if you look at it, that the risk does tend to diminish after quitting smoking. So even for those that smoke, maybe just actually telling them that it's not the end of the day, and if they actually do quit, the risk actually comes close to those for non-smokers. So I think that's smoking something that we should pursue. I should actively encourage our patients to quit, and not just, and that shouldn't just end at the clinic with an interview. I think we should now, in 2018, we should be referring these patients to specialists in smoking cessation clinics to help them quit their smoking because of the impact it can have on their disease. So the second one is having the perforating phenotype. So these are the most severe patients at the most severe phenotype for Crohn's disease. So this was a meta-analysis published in the Red Journal in 2008, and looking at 13 studies, very large, over 3,000 patients. And what they looked at is basically having a perforating indication at the index surgery versus non-perforating, and this is looking at recurrence needing reoperation, and there was a hazard ratio was around 1.5. So having a penetrating phenotype does increase your risk of recurrence. Now, for prior resections, the evidence base is not as strong. A number of observational studies have shown that a history of prior resection is a risk factor associated with postoperative recurrence. However, this was an RCT from North America, where actually the primary endpoint was they were looking at the type of anastomosis, whether using a side-to-side versus an end-to-end had a difference in postoperative recurrence. So it was a negative study for the primary endpoint, but if you look at the univariate analysis, if you looked at the patients that had more previous resections, they had higher rates of endoscopic and clinical recurrence compared to those that had fewer resections. And obviously having prior resections it's not just a risk factor for recurrence, but also it will have a bigger impact. If this patient has a second resection, it will have a bigger impact on their outlook in terms of shortcut and syndrome and etc. So next, I'm gonna go through some interesting risk factors. Maybe I don't routinely look for them, but maybe that's something worthwhile discussing with your pathologist. So these are some of the histological or experimental risk factors. One of them is myenteric plexitis. So if you remember from our anatomy, medical schools, the myenteric plexus is in the muscularis layer of the mucosa, and it's really involved in the enteric nervous system. And what was found is that in Crohn's disease, that there were neuronal lesions that were seen on the resection specimens of Crohn's disease, even on the uninvolved segments. So that suggested, they postulated whether there was a neuronal pathway for spreading of inflammation. And this was a study by Mark Ferranti's group from Leuven, it's published in Gastroenterology, where they followed up 59 resection specimens from 2 large prospective trials for postoperative prevention trials. And what they found is that having myenteric plexitis in the proximal resection margin was predictive of an increased risk of endoscopic recurrence, both at 3 and 12 months. So that's maybe something that you could, I don't routinely discuss with my pathologist, but maybe that's something you could consider in some of your patients. Now, granulomas is another thing. So what's been shown is that granulomatous versus non-granulomatous Crohn's. So granulomatous Crohn's tends to recur more than non-granulomatous Crohn's. This is a large meta-analysis of around 2,000 patients, where it showed that the risk of recurrence was higher for granulomatous Crohn's versus non-granulomatous Crohn's on the resection specimens. So we're gastroenterologists, so we scope. We like to scope, and endoscopy remains our ally and our tool that we use to assess our patients. And really, it is our gold standard for assessing a post-operative recurrence. However, our patients don't like being scoped, especially ideal. I think Uthman has also mentioned that we have a transition in our clinics at 15. So we're seeing a large pediatric population that don't like being scoped, and if they do, they require general anesthesia a lot of the time. So our patients sometimes ask us, do you have anything non-invasive that you can use to assess the disease? Well, there are some emerging non-invasive methods that we can use. I'll go briefly through them. So fecal calprotectin has been touched upon in the previous lectures, and it's been shown that a level of around 100 is a reasonable cutoff with a decent sensitivity. Ultrasound is good. It's got good sensitivity and specificity. However, it's operator dependent and requires training. So you need someone in your center to have been trained on it. MR enterography, we use it a lot to assess for mucosal healing. Now, in terms of post-operative recurrence, there is some good agreement with the Rutgers score. However, the trials were small, and there were problems with having no validation of the scoring systems. Capsule endoscopy is also a useful tool, and it's been shown it can detect lesions beyond the reach of our scopes in around 2/3 of patients. However, there is a risk of capsule retention that's significant. So if you do consider using a capsule in these post-operative patients, a patency capsule is a must, really. So I don't know how many of you uses an objective score when scoping your IBD patients, but if you're not using a score, I think this is a population that you should try to use a score. And really, the Rutgers score is one of the simpler ones that we have in IBD. And it's basically, it goes from I0 to I4. Anything above I2 is significant as a recurrence. And it's been shown, it's not actually formally validated, but it's been used commonly in most of the clinical trials. And it's been shown that it does correlate, as you can see, when you go above I2, there's a significant risk of clinical recurrence both at 3 and 5 years compared with I0 and I1. Okay. So next, so we spoke about post-operative recurrence and natural history of Crohn's disease and how we can assess it. So now we have the recurrence in front of us. Now, the patient's going to do? What are you going to do about it? What tools, what agents do we have, and what's the evidence base for them? So I'm going to go through some of the agents that we have. So the first is imidazole antibiotics. So they've been shown actually to be effective in prevention, post-operative prevention of Crohn's disease. And this was a meta-analysis of the 2 large RCTs published, which shows that it does reduce postoperative recurrence. However, the limitation with using metronidazole and the imidazole antibiotics in general is a side effects, mainly the GI upset and the peripheral neuropathy, which limits their use. 5-ASA has been looked at in detail in a lot of studies in postoperative recurrence. Now, however, if you look at the highest quality, there was some data, there was some signals suggest maybe some benefit in postoperative Crohn's disease. However, if you look at the largest trial that was done, which is a multi-center European study, which randomized around 300 patients to high dose 5-ASA of Pentasa 4 grams versus placebo, and they looked at the primary outcome of postoperative recurrence at 18 months. It was 24% versus 30% for placebo, and it did not meet the primary endpoint. However, if you want to if you want to milk the data, if you look at the subgroup analysis, it did show a small benefit in patients with isolated small bowel disease. And this study was incorporated in a large meta-analysis published by the Cochrane Group in 2009. And what they found that although 5-ASAs decreased clinical postoperative recurrence, there was no difference in really the objective marker, which is endoscopic postoperative recurrence. Sorry, next slide. Okay. So the next agent that we have is thiopurines. So before we move on to biologics, so thiopurines were looked at. This was an RCT from Leuven, where they looked at 81 postoperative Crohn's patients. Now, in this study, what they did is they gave everyone antibiotics. So there was some data that antibiotics work. So everyone got antibiotics, and the other group got a placebo as well, or a thiopurine plus an antibiotic. And what they looked at as the primary outcome in this study, as you can see, it has evolved. Now they're looking at endoscopic recurrence rather than clinical recurrence. And although initially at 3 months there was no difference in the recurrence rates, if you look at 1 year, it was significant, and there was a difference in the recurrence. So the thiopurines do reduce your recurrence rates. However, in this study, the high placebo response maybe is because everyone got antibiotics, which are already, we know, are effective in preventing recurrence. However, the largest study really looking at mercaptopurine in this case, but thiopurines in the prevention was the TOPIC trial, which looked at, it was published in the Lancet Gastroenterology Hepatology in 2016. It was a British study. It was a randomized controlled trial at 19 UK centers, and they randomized all patients, 240 patients, randomized to either having mercaptopurine at 1 milligram per kilogram or placebo, and they followed them for a maximum of 3 years. Now, their primary endpoint was a clinical postoperative recurrence or the need for anti-inflammatory rescue therapy. And this was actually a negative study. So although the unadjusted hazard ratio was positive, when it was adjusted, it was negative. However, when you look at the subgroup analysis and you look at the smoking status, thiopurines did have a benefit in the higher risk groups, which are patients with that are smokers. So this is a group that you may consider using thiopurines. Now, the problem with thiopurine in this study, the authors mentioned, is that around 60% of their patients, they didn't use metabolite monitoring in this study, and around 60% of patients in a post-hoc analysis had subtherapeutic 60 GN levels. So that also might be a factor in not meeting the primary endpoint. Now, changing gears to anti-TNF, so infliximab. I think my colleagues already alluded to this study. Was looked at by Miguel Ruggero initially with a small study, RCT, where they randomized 24 patients to infliximab versus placebo, and it showed that it was clearly superior to placebo. And this then triggered the famous PREVENT trial, which was a multi-center international randomized controlled trial, looked at 300 patients randomized to infliximab versus placebo. And this study was famously negative for the primary endpoint, and that was there was some criticisms about the composite, the primary endpoint that was chosen, which was the CDI plus endoscopic recurrence, possibly a design flaw in the study that didn't meet the primary endpoint. However, when you look at the endoscopic recurrence, there was a significant difference between the infliximab treated patients versus placebo. Adalimumab was looked at initially by an Italian group. This is an RCT published in the Red Journal in 2013. Looked at 51 post-op Crohn's disease patients, and they actually randomized them to 5-ASA, azathioprine, and adalimumab. And what it showed is that adalimumab was superior to both 5-ASA and thiopurine. And out of interest in this study, although I don't think it was powered for that, but there was no difference in endoscopic or clinical postoperative recurrence between azathioprine and 5-ASA in this study. And then we all know the famous poker trial which was published in the Lancet in 2014. It was a large multi-center trial for patients undergoing resection for Crohn's. And rather than just comparing drugs, it was more comparing a treatment strategy where they compared active care versus standard care. And it was a large number of patients, 174 in Australia and New Zealand, and looked at endoscopic postoperative recurrence. This was the design of the study. You're risk stratified if you're low or high risk meaning having one or more of the risk factors on the right-hand side. And then you're randomized to either having standard care with just no endoscopy and best drug therapy, or having active care where you're getting a scope at 6 months, and then everyone gets a scope at 18 months. If you're low risk, you get no additional treatment other than antibiotics. High risk, you get a thiopurine. If you're intolerant of thiopurine, you get adalimumab. And this was a positive trial, as we all know. So active care, the patients that were randomized to active care had less clinical endoscopic recurrence compared to standard care. And I think also an important point we get from this study is that the impact of the timing of anti-TNF was actually important. So what they found is that whatever strategy, whatever drug you choose to start from the outset, it didn't really have a difference in the outcome as long as you're actively following your patients. So if you look at the patients that received immediate adalimumab versus ones that received thiopurine and then got a step up at 6 months when they had active disease, there was actually no difference in the outcome at 18 months. So whatever strategy you decide to choose with your patient, as long as you're actively following them and you reassess your patients and step up your therapy, you can still achieve the prevent postoperative recurrence.
Dr. Al-Tawil, we have 2 minutes.
Sure. So I'm just going to finish off talking about our newer agents. So the new kids on the block, vedolizumab and ustekinumab. So we have no prospective trials looking at them. However, some retrospective data that just came up last year that I'd like to share with you. So this was a retrospective study from the Mayo Clinic, from Edward Loftus group. And what they found is that they looked at patients that received Vedo versus anti-TNF versus no biologics within 12 weeks of abdominal surgery. And what they found is that the patients that received Vedo had a higher risk of surgical site infections compared to both biologics and placebo. However, if you look at the table 1, this is a retrospective study with its inherent limitations. How the patients on the Vedo group had more steroid use and immunomodulator, which might have confounded the results. This was followed by an abstract published by Mac Ferranti from Leuven, and they found no difference in their surgical site infections in their group. So, but there might be a safety signal here for Vedo that needs to be prospectively studied. And ustekinumab, this was a large retrospective study that looked at the outcome for ustekinumab, and there was no signals for ustekinumab. So just my final slide. So how do I do it and putting it all together? So I think the most important is really to risk stratify your patient using the risk factors that we spoke about. All patients, if possible, get 3 months of imidazole antibiotics if tolerated. If you have a low risk patient, you give no prophylaxis. If you have a moderate risk, meaning one or less risk factor, consider a thiopurine, especially as we looked at the TOPIC trial if they're a smoker, an anti-TNF if intolerant. If they're high risk, you offer an anti-TNF from the outset. But I think most important is really to scope your patient. Get that post-op scope at 6 to 12 months, maybe consider non-invasive markers, and then maybe consider escalation of therapy as dictated by your endoscopy findings, and really encourage your patients to quit smoking. Thank you very much.
Thank you so much, Dr. Al-Tawil. I would like to ask the speakers to join us on the stage to take 2 questions. We'll take them from the app. We're just running a bit out of time. Talal. So the first question will be with Dr. Ashwaq.
First question here is for Dr. Othman AlHarbi. I can go. So if a patient have low trough level of infliximab, could this patient benefit from shifting to another anti-TNF, adalimumab?
I'm sorry, the question again?
If a patient have low trough level of infliximab, could this patient benefit from shifting to adalimumab?
So the question is if the patient is with low trough level to infliximab. So with these patients, I don't think that we use the infliximab for them in an optimal way yet. If they are, if the patient is clinically there is a sign of loss of response, or even if the trough level is very low in these patients, I usually try to maximize the use of the first anti-TNF before moving to the second one. I try to do this just because I may need the other anti-TNF in the future. So my first step usually to increase the dose or decrease the interval. By the way, I stand here because there was no enough chairs. So
thank you very much.
Dr. Hamad, gastroenterologist, hepatologist from Jeddah. Professor Colombo, it's really scary what we saw that we are using very little biologics. This is number one. And very interesting your slides about the 6 markers, whether they can predict a patient who can be started on biologics very early. The third point, I mean, the treat to target and the way is very long. It's very scary when you said that there is no remission here, no treatment. So some points about combination therapy, if that will increase the response.
Yes. The point is that what I was mentioning is first that the best result with our biologics are not enough. So combining biologics could be one option. This is something that we are currently exploring actually by combining vedolizumab plus Humira in a prospective study. This is already done in rheumatoid.
Which one? Can you just?
We have an ongoing study where we are combining vedolizumab plus adalimumab plus methotrexate in early Crohn's disease patients with predictors of very aggressive disease. It's a pilot study on 60 patients, mainly looking at safety. When you look at rheumatology and dermatology, they are already doing a lot of combination of biologics. But of course, there is a potential problem of safety and problem of cost. What I was mentioning is that cure is a very difficult target because in all studies that we have done so far, as soon as you stop, even in a patient in deepest remission, the risk of relapse is still high. This is why I am so obsessed now, I am working so much on this preclinical phase, because I think this is fascinating. If we could detect the disease before the first symptom, then maybe we could apply some preventive strategy. I don't think it would be with biologics, but maybe with diet, shifting the microbiome, doing something like that. And I think this is a future, more than cure, actually.
Okay, this will be the last question. Sorry, before the question, I just want to make sure everybody knows there is a satellite symposium this afternoon at 1 p.m. sponsored by Takeda, where Professor Colombo will give his lecture, and it will be chaired and co-chaired by Dr. Othman AlHarbi and Dr. Mahmoud Mosley. So we encourage you all to come and attend this event. It will be in this venue. So we'll have the last lecture before the break. The last question, sorry, before the break.
Bismillah ar-Rahman ar-Rahim. Magad al-Sharif, gastroenterologist, Eastern Province, Al-Ahsa. I would like to ask Professor Colombo. I would like, before the question, I would like to remind all of us about a very recent story. It is not very past. For many years, we were treating peptic ulcer disease with surgeries, vagotomies, and at the end of 70s, the beginning of 80s, Marshall and Warren, they discovered the H. pylori, and they took Nobel Prize for it. Can we compare this story to the story of Crohn's disease? Because to me, Crohn's disease is a perfect bacterial infection. It is a disease with abscesses, fistulas, stricture, it is a bacterial behavior. So I think we have a bacteria here, but we did not isolate it yet, and all our armamentarium is failing till now. It is very disappointing to have all of these drugs, and we end with a success rate of 17% to 25% after 1 year of treatment. Thank you very much. So should we spend more research on gut microbiome? Thank you.
This is a very intriguing question. We have looked for a unique pathogen in Crohn's disease. So far, there is nothing convincing, but I agree with you. Maybe there is still something missing. What we are also looking at now is not only the microbiome, but also the fungome and the virome. Because maybe there is something about virus, and we are just started to look at that. So far, what we believe is more this concept, I'm not sure that the word is right, of dysbiosis. This disequilibrium between good and bad bacteria. For instance, we found this adhesive E. coli, which is a strong inflammatory bug, but it's not a unique pathogen. It's just part of a disequilibrium. For instance, there is this other bacteria, Faecalibacter prosnici, which has a strong anti-inflammatory role in Crohn's disease. So we believe that this is more this disequilibrium, and I believe that maybe it's caused by diet. And actually, this is a question that I will have for you, because you are seeing more and more patients with Crohn's disease in this country. So I think this is a perfect place to look at new environmental factors. Because in US or in France and so on, it's too difficult. We have so many patients, and I think it's too late. While in this country where the disease is still emerging, I think it's a fantastic opportunity to maybe find something, a new clue as far as environmental factors. As far as environmental factors, there is something fascinating that you can do. Because it's difficult to do questionnaire, because when you are asking questionnaire about diet and so on, it's always biased. So there is a new way that we are exploring to look at the environment, is by looking at your teeth. When we are looking at your teeth, crushing the teeth, there is a way to look at everything you have been exposed to since the second trimester of your pregnancy. And just by looking at your teeth, I will be able to tell you, for instance, if you have been exposed to some metal pollution, if you have been breastfed or not, and when. It's like a tree, You are accumulating the environmental factors. So it's a fascinating new, unbiased tool to look at environmental factors. And this is what we are exploring now.